at the podium, please. Dr. Colin Tan will speak on imaging the diabetic macular edema. Colin?
Okay, thank you for the introduction. Very good afternoon, ladies and gentlemen. It's really a pleasure to be speaking at this meeting, and I'd like to just acknowledge once again my gratitude to the organizing committee for the opportunity to speak here. So I'll be talking about the use of imaging as potential biomarkers for diabetic macular edema. Oops. Oh, that's the wrong one. Oh, okay. I was wondering why someone changed the title of my talk, but you said, so yes, so I'll be talking about imaging for diabetic macular edema, and these are just my financial disclosures, none directly relevant to this presentation. So we're all familiar with diabetic macular edema. We know it's a complication of diabetes mellitus with incidence in both young and old patients, and it's a major cause of visual loss amongst diabetics. The pathophysiology is related to the hyperglycemia resulting in blood-retinal barrier disruption, as well as interstitial fluid accumulation and cyst formation. The burden of disease can be quite high in some parts of the world. And the prevalence of DME has been estimated to be at least 12.8% in some cases, and they consume significantly more healthcare resources and higher costs than patients without DME. The standard treatments, as we've heard, will be anti-VEGF treatments, potentially intravitreal steroids, as well as focal or grid laser photocoagulation. So let's go on to imaging for diabetic macular edema. The various modalities that are available to us include color-funded photography, optical coherence tomography, OCT angiography, as well as, and importantly, the role of ultra-wide field imaging. So let's start with OCT. This is the workhorse of our clinics. I can't really imagine running a retina clinic without having an OCT device available. So what do we look for? Well, on the OCT scan is a very important determinant of whether to start treatment. The typical findings would include features such as retinal swelling, cystoid macular edema, subretinal fluid, and it's been shown that these OCT can be more sensitive than clinical examination using biomicroscopy in detecting such changes, and so this is a very important tool in our practice. It's also important because there are some potential markers for functional response to anti-VEGF therapy, and amongst things that have been described are ellipsoid zone integrity, severity of the subretinal fluid, and the overall retinal thickness. And there are ongoing developments of newer devices such as quantitative tools, such as 3D segmentation and modeling of the RPE. So this is just one example of a patient of mine where patient presented with intraretinal cyst as well as subretinal fluid and retinal thickening, and even though and after just one injection the fluid has very much improved, even though there's still some findings on the OCT. OCT angiography is something that's relatively new, and it's something that we're all very excited about. We've heard a lot about OCTA at this meeting and as well as other meetings. It allows non-invasive imaging of the retinal vasculature and provides en-face flow images of both the superficial and deep capillary plexuses. One of the features of diabetic macular edema and diabetic retinopathy is that the foveal avascular zone, or FAZ, increases in size with severity of diabetic retinopathy, with a corresponding increase in the diameter of the best fit circle. In addition, there are also changes in the surrounding capillary networks, as we can see from the images here of the control eye, as well as the patients with diabetic retinopathy. Features that have been described amongst on OCTA include increase in the FAZ area, an increasingly irregular FAZ contour, reduced perifoveal and parafoveal vessel density, as well as areas of capillary dropout. So looking at this example, in the healthy eye, the vessels are quite regular and there's no areas of dropout. In the Mahal NPDR, as seen in the top right, there's areas, the contour is still fairly clear, but there are enlarged perivascular spaces. In the lower left, for moderate NPDR, the contours are more irregular and there's more areas of capillary dropout. And this is especially obvious in the severe case on the bottom right, where the FAZ is interrupted inferiorly, as well as the large areas of capillary dropout. There have been also other tools that have been used to quantify foveal non-perfusion, which can be quantified numerically. And one of the approaches is shown in one paper here, where they skeletonized the image and drew the FAZ. And then they had concentric rings around this FAZ of different zones in the retina. And they then had a color map showing the relative perfusion, as well as the standard deviations shown on the bottom row, where increasing areas of deviation from the norm are marked out in different colors, the red being the most severe. Using OCT angiography, we're also able to visualize the microaneurysms and intraretinal microvascular abnormalities, and the microaneurysms can appear either saccular or fusiform in appearance on the OCTA. But what's important is to note that sometimes on the Fluorescein angiogram, you may see some regions of microaneurysms which you do not see on the OCTA, and vice versa. So it's very important not to rely on just one device. But the advantages of OCT angiography versus Fluorescein angiography include the fact that it's non-invasive, it is rapid, doesn't require the injection of contrast, and is not affected by dye leakage, which can, of course, obscure the clarity of the region. In contrast, the disadvantages include the narrower field of view, as well as the fact that it does not show the time sequence, and that does not show leakage in case you want to look for areas of active leakage. I'd like to just round up by talking about the role of ultra-wide field imaging. Now, obviously, we don't need that for macular edema, but I think it is also relevant to assess the rest of the retina, because diabetes doesn't affect just one region of the eye, but the entire retina. So traditional fundus cameras cover between 30 to about 55 degrees field of view, whereas ultra-wide field imaging covers up to 200 degrees in a single image. As we can see over here, we can see a very large extent of the retina, and yet if we had focused on just the traditional image centrally, we would have missed out a lot of pathology in the periphery. So ultra-wide field imaging demonstrates more peripheral pathology, which is not seen on standard ETDRS photos, and studies have shown that there's increased identification of diabetic retinopathy, increased identification of vision-threatening DR, and one term that has been introduced in recent years is predominantly peripheral lesions by the group in Jocelyn, where they found that those patients with PPL had higher risk of progression to diabetic retinopathy and higher risk of progression of the retinopathy. So one useful feature of ultra-wide field imaging relative to diabetic macular edema is to assess the regions of capillary non-perfusion, which can be more peripheral, and it's been postulated that some of these areas may be a source of VEGF drive, which may cause the persistent macular edema. So it will be useful to detect this, and of course also to look for the leakage from neovascularization as is seen in this photograph. So to summarize, imaging plays a vital role in the management of diabetic macular edema, and with continuing advances in imaging devices as well as software and analyses, these will provide new biomarkers for disease severity and progression. Thank you very much.
Thank you. We do not have a question and answer session for this session, so hopefully you can catch up with the speakers afterwards. If we could have the next speakers ready to go right away, that would be great. I have a pleasure of introducing Dr. ReemaBansal, who will be talking on OCT biomarkers for diabetic macular edema.
Very good evening. Thanks to the chairs and thanks to the organizers of the VRSI for inviting me to talk on OCT biomarkers in diabetic macular edema. So why do we really need to know the biomarkers on the OCT in diabetic macular edema? Can the OCT really predict response in a patient? So despite the treatment, we know that macular edema remains one of the leading causes of central visual loss in diabetes. It has enormous medical and socioeconomic importance, and no methods exist to prospectively determine which patients will gain or lose vision, limiting the individualized risk assessment, management decisions, and speed of new drug development. A lot has been done to identify the common prognostic indicators, such as in this review, which looks at the large RCTs like the RESTORE, the Protocol 1, the BOLT, and the READ2 study. This also looked, besides the various demographic factors, it has looked at the various OCT factors also. And there are a number of factors, including the gender, the age, the severity of diabetes, the duration, the risk, the stage of diabetic retinopathy, and the various OCT parameters. So when we look at the OCT parameters, how do we predict? So if the first and the foremost feature of the OCT which has been highlighted in these studies is the inner segment, outer segment, junction layer, and the external limiting membrane. And it's very evident how much it has been talked about by the number of papers that you see. It's not possible to talk about each paper, but just to highlight one of them, that the retinal sensitivity is associated with the integrity of this layer and the external limiting membrane in diabetic macular edema. So interruption of this layer did affect visual acuity and the retinal microperimetric sensitivity at the baseline and was a more direct correlate compared to the central macular thickness. Better visual acuity, preservation of the external limiting membrane and the IS-OS layer pre-bevacizumab was associated with a better visual acuity post-bevacizumab. In patients being treated with ranibizumab, this layer defect actually improved, suggesting the possibility of remodeling or regeneration of the photoreceptor layer. Similar regenerative effects of this layer has been seen in all types of macular edemas. Coming to the second parameter on the OCT, there's a lot has been talked about the hyperreflective dots or the HRDs. These are well circumscribed, about 20 to 40 micron in diameter size particles. They have equal or slightly higher reflectivity than the RPE band. Their origin, however, is unclear. They may be associated with an extravasation of lipoproteins, or they represent the degenerated photoreceptors, or the activated microglial cells caused by an intraretinal pro-inflammatory state. So the association between these hyperreflective dots and the outcome in diabetic macular edema has been said in this paper, where the patients with treatment-naive diabetic macular edema had 82 eyes were included, and macular edema because of retinal vein occlusion were 68 eyes. All eyes initially received intravitreal bevacizumab. These were the exclusion criteria like myopia, glaucoma, media opacities, and other retinal diseases. So since all the patients received three consecutive intravitreal bevacizumab injections, the responders were the one where the central thickness became less than 300 microns or reduced by more than 50 microns after the 3 injections. The poor responders went on to get dexamethasone. So the number of HRDs or the hyperreflective dots within an area of 1500 microns from the center of the fovea was manually counted by a masked retina specialist. So if you look at these graphs, the one on the left shows the number of baseline dots in the bevacizumab responders, non-responders is significantly higher than the responders. The second one shows the number of dots in the bevacizumab responders before and after the injection. That means the number of dots has gone down after the injection. And the third shows there is not much difference in the bevacizumab non-responders. So there is a decrease in the number of dots after bevacizumab injection in the responders, but no decrease is observed in the bevacizumab non-responders. So this is a representative case of a bevacizumab responder. You can see a number of hyperreflective dots along with the macular edema, and post-injection the dots have reduced in size and the macular edema has responded. In contrast, another case of a poor bevacizumab responder where you see a large number of hyperreflective dots along with the thickness, macular edema. Post-injection, there is not much change in the macular edema, so this becomes a bevacizumab non-responder, and it was only after the dexamethasone that this patient responded, and you can see the number of hyperreflective dots going down. So this is the graph that shows the baseline number of HRDs according to the treatment response to dexamethasone implant in diabetic macular edema. You can see that there is a significant decrease at baseline in dexamethasone responders as compared to the non-responders. The second one shows the number of dots before bevacizumab injection after the dexamethasone as compared to the non-responders, which is seen in the third one. So conclusion from this study was that eyes that responded to the dexamethasone implant, that were the ones which were bevacizumab non-responders, had significantly more number of HRDs than the eyes that did not respond to the dexamethasone implants. So considering that the HRDs might represent inflammation in the retina, the inflammatory pathway might contribute more to the pathogenesis of diabetic macular edema than the VEGF pathway in these eyes. So therefore, for diabetic macular edema eyes which have many HRDs, we may infer in advance that inflammation mainly contributed to the development of macular edema and that the anti-inflammatory drugs would have more effective role than the anti-VEGF injections in these eyes. So the third parameter that has been talked is the choroidal thickness. The choroidal thickness is reduced in patients with diabetic retinopathy compared to the control patients because of the systemic effects of diabetes. Varying inferences have been drawn from different studies. There is no correlation between the degree of retinal edema or thickening and choroidal thickening. For example, in a study by Reyes et al., cases with greater baseline subfoveal choroidal thickness were associated with a better anatomical and functional response. The subfoveal choroidal thickness decreased significantly after 3 anti-VEGF injections, but the other study by Sonoda et al. Showed that the intravitreal steroids also reduced the choroidal thickness in diabetic macular edema eyes. So the fourth parameter is the drill or disorganization of the retinal inner layers as a predictor of visual acuity in eyes with center involving diabetic macular edema. Now, this is defined as the horizontal extent in microns for which any boundaries between the ganglion cell inner plexiform layer complex, inner nuclear layer, and outer plexiform layer could not be identified. So if you look at on the left, you cannot appreciate these layers in the 570 micron area. So there, the drill is present in this. And on the right, as you can appreciate all these layers very well in the central 1 millimeter zone. So the drill is absent on the right side. So the association of drill extent change with visual acuity change is more consistent and robust than that for change in any other spectral domain OCT parameter that they evaluated. On an average, within the central 1 millimeter wide area of the fovea, for every drill increase of approximately 300 microns from the baseline to 4 months, the visual acuity is reduced by 1 line at 8 months follow-up period compared with the baseline. So disruption has been hypothesized to result when the bipolar axons snap after the elasticity limit has been exceeded because of the persisting edema. This study also supports the use of drill as a surrogate marker of visual acuity and potentially as a predictive biomarker for future visual acuity outcomes in eyes with diabetic macular edema. Now you see that on the left you're not able to distinguish any inner retinal layers in the 1 millimeter central zone. So there is edema along with drill. On the right side, after the injection, the edema, although the edema has resolved, but the drill persists. On the other hand, on the left side, you see there is edema, there is no drill, but after the injection, that means the layers are preserved, and after the injection, the layers are very preserved along with resolution of the macular edema. So the OCT biomarkers as functional outcome predictors in diabetic macular edema treated with dexamethasone. This was a study of 299 eyes, of which 209 eyes were treatment naive and 90 eyes were refractory. So the patients included in this study were more than 18 years with type 1 or 2 diabetes mellitus with diabetic macular edema, and all were treated with the dexamethasone implant. So various chart records were documented, including the demographic data, the metabolic parameters, and the OCT features. These were the morphological features that were studied on the spectral domain OCT. Serous macular detachment with cystoid diabetic macular edema showing retinal elevation with an optically clear space between the sensory retina and the RPE. Second was the grading of intraretinal cysts, cystoid diabetic macular edema with the giant outer nucleus cyst, as you can see with the asterisks, as well as cysts in the inner nuclear layer. Diabetic macular edema associated with focal vitreomacular traction. Okay, 1 minute. Yeah. Okay. And they were grading of the hyperreflective foci as few, moderate, and severe, depending upon their numbers less than 10, 10 to 20, and more than 20. So grading of the integrity of the eyes OS layer was also done as irregular and continuous. partial irregularity, and complete discontinuity of the IS-OS layer. So based on the OCT analysis of these layers, the grading was done by 3 experienced retinal specialists. So it was said that 43% of the eyes gained more than 10-letter improvement, and 49% gained less than 10-letter improvement, and 7% lost more than 10 letters. The central macular thickness, 68% gained more than 20% of the improvement in the central macular thickness. So these were the parameters that were significant at 2 months. You can see the IS-OS continuity, the location of the hyperreflective dots, and the vitreomacular interface irregularities. At 4 months, in addition to those, the baseline visual acuity and the presence of subretinal fluid was also statistically related to that. So I'll wind up here. So these parameters that were different in the dexamethasone study as compared to the VEGF for the presence of subretinal fluid, which was significantly associated in the dexamethasone study. So conclusion was that presence of subretinal fluid, the IS-OS continuity, absent HRF, and attached to retinal interface were the biomarkers that could predict better visual outcome after the dexamethasone implants in eyes with diabetic macular edema. Thank you very much.
Who's going to talk on the overview of intravitreal steroids in treatment of diabetic macular edema and focus on iluvienimplant.
Thank you, though I'm not going to focus on anything in particular. No focus on a product. It's not my desire to do so, but I will talk about my algorithm for taking care of patients with diabetic macular edema based on scientific data, clinical trials to clinical practice by way of financial disclosure. So I think an important part that as we're learning more and more about the management of diabetic macular edema is the role of inflammation, and that may explain why many of our patients don't show as robust a response as we'd like. There's a huge release of inflammatory mediators, the cytokines and chemokines, including VEGF, but also many interleukins and monocyte chemoattractant protein that lead to diabetic macular edema. And we need to make sure that we're taking care of all these factors to get good responses in some of our patients. The study by Dong et al. Looked at 100 patients, 100 control patients, and measured aqueous levels of cytokines compared to patients with diabetes, and showed that with patients with diabetes, there's huge increases in interleukin, monocyte chemoattractant protein, and VEGF. VEGF is, of course, key and important. In a non-diabetic, it's under 100. In a diabetic, it's about 1,000. This study went on to then look at the level of retinopathy, and what was interesting here is that VEGF is high in all of them, regardless of the level of retinopathy. So when a non-diabetic, it's a very low level, and then suddenly a switch goes on, and in a diabetic, the VEGF levels are very high. In contrast, the interleukins and some of the other inflammatory cytokines start very low with early retinopathy, and over time, as retinopathy progresses, become much higher. So they seem to be sensitive to levels of retinopathy, which is a surrogate measure of time, whereas VEGF is always high in these diabetics. So clearly, the VEGF is an important thing that needs to be addressed, but over time, it may be that these other inflammatory mediators need to be addressed as well. In fact, if you look at this interesting study by Sonomas et al. Of simply 11 patients with bilateral diabetic macular edema, one eye was treated with triamcinolone and the other eye with bevacizumab. The eyes treated with triamcinolone showed, without much surprise, if you measure their aqueous cytokine levels, pre-injection compared to 1 month after the injection, a reduction in the interleukins, monocyte chemoattractant protein, but also reduction in VEGF. We know that steroids are a good but not great VEGF inhibitor. Also not surprising under the bevacizumab column is that bevacizumab is an excellent VEGF reducer, reduced it by 99%. However, what was surprising in this study is that bevacizumab reducing VEGF levels so dramatically, you would think that the other inflammatory cytokines would have some response, either upregulation, downregulation, some response, but they seem not to have any change whatsoever. So anti-VEGF is really a single bullet, and we thought there would be more dynamic in that sense. So it reduces VEGF wonderfully, but it seems not to have any impact on the other inflammatory cytokines. So if there's an eye that has a lot of the other inflammatory cytokines, one wouldn't expect the VEGF reduction to have any impact on that. So in this cartoon, I show you that there may be eyes that have a lot of VEGF and not that much other inflammatory mediators, and those would be very responsive to VEGF. Whereas conversely, there may be eyes with high levels of non-VEGF inflammatory mediators, and we would not expect those to respond to VEGF inhibition. And it's worth noting that steroids may be effective in treating both types of patients. In fact, we know that a lot of our patients with diabetes don't show an adequate response to VEGF. From the DRCR protocol I study, half of those patients in that study, there's 4 groups in that study, 2 groups that received ranibizumab, 1 that received triamcinolone with laser, and the other was laser alone. But if you look at the 2 groups that received ranibizumab, only about half of those patients had an early and consistent response to VEGF inhibition. 25% of them were dubbed non-responders, another 25% were suboptimal responders. That seems quite extreme, perhaps more than what we're used to in our patient population, but it's worth noting what they found there. Similarly, in the DRCR protocol I studied, there was the early analysis looking at the 50% of patients that did receive ranibizumab. They all received 3 loading doses at time 0, 4 weeks, and 8 weeks. And when they were evaluated at 12 weeks, in this analysis, they were scored based on how well that they had responded on visual acuity, and about 40% of them were dubbed poor responders because they had less than 5 letters gained, and 37% were the good responders with 10 or more letters gained. They tracked these patients over 3 years, and what they found were these so-called swim lanes, that if you were a poor responder early on, you were likely to be a poor responder over the course of the next 3 years. Only about 30% of patients ever crossed from the red line up to the blue line, the desirable line. So patients it seems to be that after 3 injections, there's a lot of data that one can look at and understand that may be relevant for their outcomes, their prediction of whether they're going to respond to VEGF inhibition or not. In fact, from the DRCR protocol I, here's the sort of one of the real-world lessons from these studies. About 28% were 3-line gainers, as you can see here in orange and green, orange and turquoise from the ranibizumab groups. If you then looked at the subset analysis of those patients that were pseudophakic at baseline, suddenly in yellow you can see the triamcinolone group join those. They seem to be as effective, the steroid, as effective as VEGF inhibition in the pseudophakic patients once you remove the problem of cataract out of the way. A non-trivial problem, of course, but it's worth noting that. If you look at the steroid implants, and here there is some mention of the iluvienimplant, you can see that in their study, that was also 28% were 3-line gainers. This seems to be a consistent finding in many studies. What was particularly interesting was the sham control group. In yellow, you can see here, in this study, everyone was masked, and patients were allowed to be treated at will 6 weeks after initiation of therapy if there was no response, and many of them received VEGF inhibition. What was particularly interesting is when they looked at the median duration of the diabetic macular edema, about half of them had diabetic macular edema that was about 2 years old prior to enrollment in the study. When they looked at those that had less than 2 years, or 1.73 years, you can see in blue and orange on the left of the slide, blue and yellow rather, that whether they were treated with steroid implant versus the sham control group, it was largely driven by anti-VEGF therapy. Those were equivalent responses. It was those with chronic disease that seemed to have a robust response to steroid, but a less good response to the sham control group, again, largely driven by VEGF inhibition. This was further corroborated by the RISE and RIDE data set, this fantastic study that led to the approval of ranibizumab for DME, not the treatment groups here, but rather the sham control group, when one was allowed to have diabetes lasting for 2 years before treatment was initiated, and finally VEGF was given, there was essentially no response. Perhaps the other inflammatory mediators levels were so high that just lowering VEGF alone was no longer going to be effective. And again, further corroboration from the RESTORE study, which showed a crossover at 1 year. There's a couple of lessons here. 7 to 8 letters gained is a typical real-world study. And you can also see that after 1 year in the crossover, there was a blunted effect, not a zero effect, but a blunted effect, suggesting that by 1 year, already a lot of the VEGF inhibitor, the non-VEGF mediators rather, were rising enough, but by suppressing VEGF, it was able to somewhat treat the disease, though it took longer to get better control of the disease. And Dexamethasone, that study was a poorly designed one with injections only every 6 months. We know that this is a very effective treatment, but it lasts only about 4 months or so. And you look in the real-world studies, in fact, you see what's something that is more consistent with our real-world experience. Treatment-naive patients, 12 letters gained with a median time to re-injection of 5 months. Refractory patients, which is where I mostly use the Dex implant. I tend to rarely use it as first-line therapy, but I use it as for my refractory patients, 8 letters gained with a median re-injection time of 4 months. And this is further corroborated by a large number of real-world studies with Dex implant, all centered around the same finding. Again, cataract is a concern, but the good news is whenever you do that the Dex implant is very protective against macular edema when you're doing cataract surgery. The IOP management tends to be easier with this steroid than with the other steroids such as triamcinolone and fluorescein, that you tend to have a very predictable response. About 10% of patients will have an IOP elevation after a single injection. And in fact, in a comparison study, analysis rather, one showed in blue that triamcinolone had a higher risk of intraocular hypertension compared to, in pink, those with receiving Dex implant. So the management with Dex implant tends to be easier. In the meta-analysis that was done about a little over a year ago by Khan et al., looking at patients who've been gotten at least 6 anti-VEGF injections and had a suboptimal response, this is over 3,800 patients, all the studies seem to favor going to Dex implant rather than continuing with VEGF inhibition in that analysis, in that meta-analysis that was done. Safety is an issue that's been raised by Bob Avery. I still don't know what to make of the issue, of the safety issue, but he did, in that meta-analysis looking at RISE and RIDE and VISTA and VIVID, there were some concerns in this very ill population. Our diabetics with DME tend to be our sickest patients. There was increased risk of mortality, and it's worth considering that. I'll skip to the concluding slides here to say that so both steroids and anti-VEGF agents are effective for DME. Both the implants, the steroid implants both work early and late. Most patients benefit from steroid therapy, but almost 40% are non-responders to or suboptimal responders to anti-VEGF. And the early study from Protocol I gives us some information that after 3 injections of anti-VEGF, we have a lot of data, we can make some decisions. So what do? I typically initiate therapy with anti-VEGF injections. It's important to discuss. If you could just keep this concluding slide on for about 30 seconds, I'll finish up then. Thank you. I typically discuss systemic management with our patients. A1C is important, blood pressure, lipid levels. Systemic safety concerns may exist, but I'm not sure what to do about it. Chronic diabetic macular edema may show a limited response to anti-VEGF, as we saw from the RISE and RIDE sham control group. However, it's difficult to identify these cases. I think the prior speaker was trying to address some of these issues, but we don't have any good method of identifying who's really a chronic patient, so we're empiricists. I start treating with anti-VEGF and see if there's a response. But if there's eyes that I'm suspicious that are likely to be chronic, I'm maybe more likely to switch from anti-VEGF to steroid implants sooner. When a patient shows a suboptimal response, whatever that might mean to each of us, after 3 anti-VEGF injections, I begin to think about alternatives. I rarely switch after just 3 injections, but I begin to contemplate it. If they were initiated on bevacizumab, I would contemplate switching to aflibercept. If they're already on aflibercept, then I would consider going to the Dex implant. And finally, the steroid implant therapy I consider even earlier in my treatment algorithm. If there's a recent myocardial infarction or stroke, if the patient's been vitrectomized, or if their eye is pseudophakic, or if they're unable to come in on a monthly basis. Thank you for your attention.
Thank you, Barry. Next speaker is Dr. Bill Meiler, who will update us on management of DME.
Thank you very much. I think you'll hear a little overlap in my presentation from Dr. Kuppermann's, and probably a bit more when Dr. Kim speaks after me. But I'm going to just reflect on kind of the current as well as future management of diabetic macular edema. I have no financial disclosures. We all recognize that diabetes is an incredibly important health issue, not only from the visual standpoint that we deal with, but from the health and life standpoint. Over almost 500 billion diabetics by 10, 15 years from now. It's a problem that's growing on an annual basis. You combine this with high cholesterol, high blood pressure, smoking, and these patients have a substantial risk of dying from their diabetic disease. So we deal with part of their problem, that of the visual concerns. Here's a time course of what's happened over the last 30 years, especially the last 10 years for treatment of diabetic macular edema. For years, we only had focal and/or grid laser therapy. It was effective, but it really only led to stabilization or perhaps a half a line or so of visual improvement. Finally, anti-VEGFs were introduced in the mid-2000s, but the trials in DME were a bit later than that. ReemaBansal was approved in August of 2012. This is, of course, in the United States. Aflibercept in July of 2014, and of course, we've been using bevacizumab for a period of time prior to that time. Dr. Kuppermann talked very nicely about the issues of dexamethasone, approved in 2014, and fluorescein in the form of iluvienimplant in August of 2014 as well. So these are all options we have, and I certainly agree with Barry that our primary treatment is almost always in the form of anti-VEGF therapy with steroids utilized a bit down the line. This is some data that Barry showed also earlier, that ranibizumab RIDE and RISE trials with very prompt responses in the 2 parallel trials. The sham group, of course, did not fare well at all. And then when rescue came 2 years down the road, as was pointed out, there really was very little or no impact when you switched over to anti-VEGF therapy. So we recognize that this is treatment that should be initiated promptly when we see patients with diabetic macular edema. The trials of VISTA and VIVID with aflibercept, once again, showed some very similar wonderful results with a rapid response to therapy. And once again, the arms of the control group with laser did not fare well, likewise maintaining vision, but really having a minimal visual gain over that 2-year time span. This was followed by the head-to-head trial of ranibizumab, bevacizumab, and aflibercept, conducted by the DRCR network. A wonderful trial comparing the 3 agents and looking at also, you could add in focal laser rescue at roughly a half a year, depending upon results based on OCT testing. At 12 months, all agents did show improvement in center-involved diabetic macular edema. The biggest advances at year 1 were with aflibercept, 18.9 letters, in contrast to bevacizumab and ranibizumab, which didn't have quite as robust responses. By 2 years, however, the data was quite comparable for all groups, so we know that patients can fare very well with any of these agents, but perhaps, like I said, at least at year 1, we saw a better result with aflibercept. Systemic adverse events were quite limited in all groups, and this data was published about 3 years ago now. Now, if we look at the DRCR-NET protocol, visual outcomes with aflibercept were maintained in year 2, requiring fewer injections. The first year of therapy required roughly 9 injections. Year number 2 required approximately 5 injections, so it becomes a lessened need for treatment as you go from year 1 to year 2. If you look at this, what's called area under the curve, the more rapidly a patient recovers vision, of course, they enjoy better vision early on. And so even though at year 2, all agents were quite comparably effective, if you can recover vision quicker, those patients do enjoy a better quality of vision more rapidly early in the course of the treatment protocol. Protocol S from the DRCR-NET looked at the issue of patients who have proliferative diabetic retinopathy, comparing laser with anti-VEGF therapy, in this case utilizing ranibizumab. I think that, as you all are aware, once again, it showed that either agent or either protocol arm could meet success as far as stabilization of the high-risk retinopathy. There also was a study called Clarity, which was an aflibercept-sponsored trial looking at a similar comparison between aflibercept versus peripheral scatter photoglycosis therapy for high-risk retinopathy. That study likewise shows that aflibercept in this setting was comparably, or was non-inferior and actually superior to the use of peripheral scatter photoglycosis therapy. Dr. Kuppermann covered very nicely the issue of the corticosteroids. I'm not going to reiterate that point. And keep in mind that the DRCR-NET has had a multitude of protocols, now over 30 protocols, and looking at pretty much every combination of treatment for the issue of diabetic macular edema, as well as proliferative diabetic tyrosine phosphatase may activate the Tie2 and have numerous potential functions, including immunologic activation, combined with VEGF suppression. So here, once again, studies have been ongoing. Aerial pharmaceuticals, the AKB 9778 has looked at this issue of inhibiting HPTB beta and lessening the amount of edema. The studies are ongoing in terms of not only cultured cells, but early phase trials. And the angiopoietins also have a number of studies looking at the impact of these types of agents in the realm of either single agents or more likely supplements to our treatments with anti-VEGF therapy. So future treatments are quite vast, probably won't have the impact that we have at the present time with our anti-VEGF and or corticosteroid agents, but these may supplement our ongoing treatments as time goes by. So watch for further activity along numerous fronts of treatment in the realm of DME. So bottom line is that in existing to our current array of anti-VEGF therapy and corticosteroid therapies, these new classes of agents are coming forth. They work from different mechanisms of action. They potentially may serve as standalone agents, but more likely will have a supplemental effect to our anti-VEGF therapy. They may increase our lasting effects, and they may bring more responders to some of our patients who don't respond well to anti-VEGF alone. Just a final word in my last minute regarding drug delivery. Obviously, if we can take our existing drugs and get them to the back of the eye or keep them in the back of the eye better, that's wonderful. where of course, we may have some new agents that work even better than what we have at the present time. So we're looking at means of trying to deliver the drugs better into the back of the eye, enhanced topically delivery, suprachoroidal delivery, transscleral microcurrents, intrascleral fine needle deliveries, and of course microspheres and nanoparticles. At the present time, a number of studies are ongoing looking at different types of reservoirs or agents that can be put in and around the eye and keep them there for a prolonged period of time. So once again, a very exciting field. Anti-VEGF bar is very high, corticosteroids are helpful, and new arrays are coming forth as well. Dr. Kim is going to tell us now which of these agents are truly the best. Thank you.
Thank you, Dr. Bill Miller, for giving us the update and also telling us what is in future in store for us, all of us, to tackle DME. Now I request Dr. Judy Kim. She's going to tell us what is the best drug for diabetic macular edema.
Thank you for the introduction. Thank you also for the organizing committee for the invitation here. As far as disclosure goes, I did serve as vice chair of DRCR-NET, but the opinions here are mine and not of the network. As Dr. Meiler mentioned, Diabetic Retinopathy Clinical Research Network was formed to facilitate multi-center clinical research of diabetic retinopathy initially, but now we are looking at age-related macular degeneration, hereditary retinal degenerations, and other retinal diseases as well. Since its inception in 2002, over 24 studies have been either completed or are ongoing or in planning position. Of these studies, one of the most important study, I would think, is the Protocol I that many of us already heard about. It showed that compared to then standard of care, focal grid laser treatment, ranibizumab or anti-VEGF with prompt or delayed laser was more beneficial in visual acuity gain. And this improved visual acuity gain was maintained over 5 years, even with less number of injections during that follow-up period. Now, at least in the United States, there are 3 anti-VEGF that's available: ranibizumab, aflibercept, bevacizumab. These agents differ in their structure, their molecular weight, and their molecular characteristics. For instance, aflibercept and ranibizumab are FDA approved in the United States. Bevacizumab is not. And some people may prefer on-label treatment versus off-label. Secondly, and perhaps more importantly in this economy, the difference in cost of these medications. There's a huge difference, and there's a drive to use bevacizumab first as a step therapy in the United States. Also, some of these medications, such as ranibizumab, come pre-filled, and bevacizumab is aliquoted in compounding pharmacies. So in a busy clinic, someone who's injecting lots of these drugs, perhaps one that's already pre-filled may be preferred. However, with bevacizumab, we've noticed some recent complications. What are these? These are silicone oil droplets that are coming out of the insulin syringes into which these bevacizumab were aliquoted into. And some of these patients actually were symptomatic enough that they required vitrectomy surgery. So, having said all of this, which anti-VEGF drug or steroid for DME? Well, Protocol T at least addressed the anti-VEGF issue with aflibercept versus bevacizumab versus ranibizumab, and we all know that at year 2, aflibercept seemed to win out over bevacizumab, while ranibizumab did catch up by year 2 to aflibercept. However, there was some difference in terms of baseline visual acuity. Those with moderate vision loss, 2032 to 2040, which accounted for actually the half of the subjects that were enrolled, there was no difference. So with moderate vision loss, any of these agents would be good, whereas with more severe vision loss, 20/50 or worse, we found that aflibercept was superior to bevacizumab. So we may also look at baseline visual acuity to decide which drug that we want to pick out of the refrigerator. What about central retinal subfield thickness? The study found that for moderate vision loss patients, both aflibercept as well as ranibizumab were superior to bevacizumab. For 20/50 or worse visual acuity, only aflibercept was superior to bevacizumab, statistically significant. So to summarize this, we found that all 3 anti-VEGF agents are similarly effective when we're treating DME with vision loss. When visual acuity loss is mild, I think any of these agents can be used, but when vision loss is more significant, we may want to consider aflibercept versus bevacizumab. And even with mild vision loss, if center subfield thickness is greatly thickened, then we may want to consider aflibercept versus bevacizumab. So put this all together, I came up with this algorithm. It is not anything that I want you to consider, but it is something that does go through my head when I have a patient sitting in front of me. So I look at the visual acuity, and then I divided the OCT thickness to 500 microns, greater or less. Why 500 micron? It's simple, it's easy for me to understand, and during the protocol designs, this was considered to be thick. So for mild vision loss, less thickening any of the anti-VEGF, more thickened aflibercept or ranibizumab. For severe vision loss, less thickening aflibercept or ranibizumab, with more thickening, perhaps aflibercept. Of note, as Barry alluded to, after at least 6 monthly injections of anti-VEGF agents, for some eyes still had unresolved diabetic macular edema as well as vision loss. In fact, in protocol I, 40% of the eyes still had diabetic macular edema, and protocol T, anywhere between 32% to 66%, depending on which anti-VEGF agent. So, what about steroids? As Barry had mentioned, in pseudophakic eyes, it did do it just as well as ranibizumab. So protocol U was designed for refractory DME. This was phase 2 trial to see whether we should go on to phase 3 or not, using dexamethasone in combination with ranibizumab versus ranibizumab alone. Because Dr. SriniVasSadda, last but not least speaker, will be talking about this, I'm going to just give you the main result with the visual acuity. What it found was that ranibizumab alone compared to combination group, there was no difference. What about retinal thickness? There was difference. The combination group did thin out the retina better, and the area under the curve was also greater. However, it did not show up in the visual acuity data. Finally, fluorescein acetonide implant, which is another steroid that we have at our hand. It is non-biodegradable. It has a cylinder tube, so each time you inject, these tubes remain in the eye. What I found with phakic eyes, it's really hard to see this after injecting. With pseudophakic eyes, as I inject, I try to put it more anteriorly right behind the lens so that I could actually see this implant going in. Otherwise, it's really, really hard to find. Well, at least in the clinical trial, the pivotal trial, during 3 years, 75% of subjects needed only 1 injection, and 30% with 15% improvement in vision. So for those patients who may require long-term treatment with less frequent injections, this may be an option. There was a user study which looked at the retrospective chart review of ILUVIEN implantation, and then there's a Paladin study that's currently ongoing. It's a prospective study. I will talk about the user study, which already has some data. What the study found was that before the implantation with ILUVIEN, patients required, on average, 1 treatment every 3 months of some sort. Could have been Ozurdex, could have been anti-VEGF or some sort. However, after the fluorescein implant injection, on average, they only required 1 injection, 14.3 months. Interestingly, the interval between injections required varied depending on the baseline visual acuity at the time when the ILUVIEN injection was performed. If the patient had good visual acuity, the injection lasted 22 months. However, if the patient had poor visual acuity, another injection required, on average, 6.7 months later. So in some patients, especially those with good visual acuity, ILUVIEN may last longer. We always think about pressure elevation when we use steroids. Well, when we use a fluorescein implant, we already have tested them out with other steroid implants, such as Ozurdex or topical steroid. As a result, we've already selected out those who are steroid sponsors. So as a result, in Paladin study, as well as in user study, there did not seem to be any steroid adverse events. So in my practice, I consider steroids non-responders for anti-VEGF, those with recent strokes, women who are pregnant or breastfeeding, pseudophakic eyes, non-steroid responders, and those who require longer treatment interval. However, anti-VEGF agents are my first line of treatment. What about laser? Should we get rid of them in this era of anti-VEGF? I do not think so. I still use it. I still teach my fellows how to inject, and I do think that it has a role in extrafoveal DME. So, which is the best drug for diabetic macular edema? Well, it depends, and I think we need to think about the patients sitting in front of us as to what their needs are. And while we have lots of options which may confuse us, I think we can be guided by some of these clinical trial data to help us to help our patients see better at longer. Thank you very much for your attention.
Thank you, Judy, for a very nice talk. We move on to the last talk by VRSI2018. He's going to talk about Protocol U.
Great, thank you, Mangat. I was asked to talk about Protocol U, and so these are going to be my opinions and interpretation of the results and not of those of the network. So as Judy highlighted in some of the slides she showed, one of the things we know from the DRCRNet trials is that a substantial number of patients still have persistent diabetic macular edema after 6 injections. Now, they're getting pretty good vision, but the edema persists. So the question is, what do you do about that? And we obviously heard from many of the previous speakers emphasizing that steroids remain a good option for these individuals. So the question is, when you have patients with persistent edema, do you keeping on with the anti-VEGF? And we know that can lead to good outcomes. Or can we do better by perhaps adding steroids into the mix? And so the purpose of Protocol U was really to study that question and to see if we could actually get enough information that might actually warrant doing a larger phase 3 study. So patients who had at least 3 injections were eligible to participate in this study, and the study went on for 6 months. And so even though they had 3 injections, for good measure, to make sure they all had at least 6 and to make sure the edema was truly persistent, patients were given another set of 3 injections, and those that did have persistent edema at that point were finally eligible for randomization to either continuing on the ranibizumab injections plus an additional sham injection, or receiving ranibizumab plus the dexamethasone. And so again, that was conducted over the next 6-month period. The groups are well balanced at baseline, so that was a good thing. Randomization worked well. And in fact, in terms of the treatments given, patients actually received a similar number of anti-VEGF injections, and even the sham versus steroid injections very similar. Most of them required a second injection through the course of the 6-month follow-up. Judy already pointed out the main top-line vision results. The ranibizumab, the patients who were continuing on just ranibizumab monotherapy, they did pick up an additional 3 letters, so you can have further improvement if you just keep on going with anti-VEGF therapy. And that was fairly similar to the patients who had dexamethasone implant added on top. But there are some, and I will point out that there are some additional complexities because the trial did plan to do some additional subgroup analysis. So these are pre-planned analyses. And in fact, as probably most of us suspected, there was a difference depending on the lens status, where pseudophakic patients actually seemed to do a little bit better with the combination with adding the steroids, whereas phakic patients, sort of the opposite relationship was observed. So you can see how this kind of canceled out in the top line. In addition, when we look at the combination group versus the ranibizumab group, we observed that there were, in fact, more patients who were 3-line gainers in the combination group, and there seemed to be, although not statistically significant, more people who were worsening in the combination group. And again, if you look to see why they were worsening, cataracts in phakic patients phakic patients certainly seem to be the culprit, and so we suspect that cataract development was certainly, even early on, may have been a potential issue. The central subfield thickness told a somewhat different story, as Judy pointed out. There was some further reduction in edema if you kept on going with anti-VEGF therapy, but adding steroids did seem to facilitate an additional drying effect, and I think that fits a lot of our clinical experience in using steroids, and you can see the magnitude of the difference was substantial, over 50 microns, in fact. Okay, what about safety? Not surprisingly, I mean, Barry pointed out that amongst the steroids, dexamethasone seems to be a safer alternative, but of course we do expect to see some pressure elevations in this sort of all-comer population. So about 29% of patients did have some type of increased IOP any visit. Actually, not too bad, I would say, but in any event, these are patients who can then be treated. But that is an important complication or side effect to keep in mind. But when you take these clinical trial results, and I think ultimately, for me, I look at these trial results and I sort of figure out, well, what am I going to do with this information in my own clinical practice? Because I always find with these trials, they always leave a number of additional questions, which is a good thing, because that way we can do more trials. But in any event, one of the things that we observed was that even though the vision didn't improve overall, when you looked at phakic and pseudophakic combined, we did see that steroids seemed to dry the retina better. So this leads to some potentially unanswered questions. I mean, yes, the visions were good, but would they have been even better if the retina was dried sooner? I mean, if I was patient, I'd kind of want to have the best vision I could get. So how do you know that vision wasn't left on the table? And so I think that's an important consideration. And then it's clear that lens status and steroid response may be factors that could modulate decision making, but this study was too small. It wasn't powered to answer this type of question definitively. So I thought I'd show a couple of case examples that sort of inform my thinking about how I address these patients. So here's a patient who has macular edema from diabetes, and this patient was started on bevacizumab therapy, and 3 months later the vision was still somewhat poor, and so they were continuing on bevacizumab, but ultimately they were switched to ranibizumab, and their vision, remained poor. They still had persistent cystoid macular edema, and unfortunately, over time, the retinal situation seemed to worsen. This retina looks pretty bad. I might have thought, like, gosh, time to throw in the towel. But in fact, this patient was treated with a dexamethasone implant, and the vision did improve. And some of you may have looked at this previous scan and said, "Oh, this retina is toast. I mean, this is not going to get better." But actually, if you look at the follow-up, you can see how this patient could somehow potentially see 20, 60, 20, 40. You can see the outer retinal bands are intact at a relatively close proximity to the foveal center. But I'm highlighting this case because sometimes you don't always know what the vision potential of a patient is. And contrast that to this other case of a patient, poorly controlled diabetes, poor vision right from the get-go, due to macular edema, was treated with aflibercept in both eyes. You can see had fairly substantial macular edema. The aflibercept was continued for a total of 6 injections as the edema persisted. This patient was treated with Dex implants, and the edema nicely resolved, as you can see here. And commonly see that sort of drying effect. In this case, though, the vision didn't really improve all that much. And I guess the reason I want to highlight this is that one thing that we can achieve, we think, in steroids is a better drying effect. It doesn't mean that all patients will dry. We saw in Protocol U that there could be additional drying. And I always like to use the steroid challenge as a probe of sorts to see what the vision could be when the retina is maximally dry. Because if I could perfectly predict, and throughout this meeting yesterday at Rishi, and here we've talked about different OCT biomarkers that can help us in predicting vision, and they are useful, but they're not 100% predictive. So for a particular patient in front of me, I often ask myself, what would the best possible vision for this patient be? And so to summarize, I think that there's compelling evidence from the DRCnet and elsewhere that you can get better drying of the retina with steroid therapies. And again, clearly Protocol U showed us, and that's a study, again, with the limitations we've talked about, that the vision certainly did not improve in all comers. Okay, that is clear. But at the same time, I would argue that drying the retina may allow us to see what the maximum achievable vision is. Okay, once we ascertain that, that can then be useful to us as setting a target for our future decision making. Because again, as I said, if I could be confident in all cases of predicting it, then maybe I wouldn't need to do this. But I view this as a great diagnostic challenge, or tool, if nothing else. So I think diabetic macular edema and diabetic retinopathy in general is I think fantastic in a way, in the sense of from a management standpoint, because it really allows us as physicians to use the art of medicine. We consider so many factors: lens status, steroid response history, other comorbidities that the patient may have, such as glaucoma, how compliant they are. All of these things may impact our decision on when and if to introduce steroids. And I think that that's going to be an ongoing discussion. Thank you.
Thanks to all the speakers and audience for your attention. Dr. Dogra would like to make a few announcements regarding this evening's events.
We have come to the end of the session, and subsequently we're going to have probably meeting here. So maybe we'll have to all move out at this time. The meeting is for the VRSI members. Thank you very much.
And then there will be a dinner at 7:30.